we talked about it in part because not too long ago, we spoke about the non-motor symptoms of Parkinson's disease. So we think of Parkinson's disease as being primarily a problem of movement. And that's how most people see it. Tremor, slowness, rigidity, gait problems, problems of using fine motor, the hand and doing fine motor tasks. And we know that there are non-motor symptoms, mostly cognitive changes, in other words, changes in the ability to think, various aspects of thinking, very special patterns of decline in thinking, and emotional differences that are non-motor, and that is the frequency of depression, for example, problems with sleep. So we've talked about this. Now to bring up the autonomic nervous system in Parkinson's disease gets you a little bit deeper, because when I talk about autonomic nervous system, autonomic means automatic. Automatic means it happens without you having to think about it, right? So there's a part of the nervous system that does things automatically. Thank God. It would be horrible if you had to remember to breathe. You have to remember to do each heartbeat. You have to remember to defecate, because it'll happen automatically. The thing about some of these automatic functions is that on some levels there's a bit of voluntary control. So the way that we were designed, we can voluntarily inhibit our sphincter. So that's wherever there's volitional control, that part of the nervous system uses what are called skeletal muscles. The skeletal muscles always come under voluntary control. So the skeletal muscles move your eyes. You can voluntarily gaze in all directions. Voluntary muscles tighten the sphincter so you don't poop in your pants. Voluntary muscles inhibit the urinary sphincter so you don't pee without releasing that. But the actual bladder, the intestines, the muscles of the arteries all have a smooth muscle. And those are not automatic. Those are not under volitional control. So the contraction of the bladder, the movement of the bowels, which constantly is moving, especially after a meal, the tightening of the arteries to adjust blood pressure, those are all involving smooth muscles that are part of the autonomic nervous system mediators. In other words, they carry out the functions of the autonomic nervous system. So I'm going to describe its structure. What is it? Well, you can actually see the autonomic nervous system. There's a brain component of the autonomic nervous system. It starts in the hypothalamus, which is at the base of the brain, and neurons project to a number of ganglia, which are collections of brain cells that are outside the brain. They're called ganglia, and they line both sides of your spinal cord. And there are some of the ganglia of the autonomic nervous system. Ganglia are nothing but a collection, like a village of neurons, that are in various organs. So, for example, the bladder has a collection of autonomic nervous system neurons that mediate the constriction of the bladder. They also can determine the tone of the bladder. And all this is automatic. So the nervous system that is made up, the autonomic nervous system is made up of brain cells and fibers in a very connected way, and we divide them into two types, sympathetic and parasympathetic. The sympathetic autonomic nervous system, what does it do? It acts like in harmony to do one thing. What does the sympathetic nervous system do? This is an easy way to remember it. The sympathetic nervous system is what becomes active when you're frightened or need to have immediate action. Like when you're about to be attacked by a saber-toothed tiger. What happens is your heart rate will speed up, your pupils will dilate, your hair stands on end, blood is shifted from the gut to the muscles, and you're ready to run. And it's just like adrenaline being released. In fact, adrenaline, in a sense, is the massive driver of the survival reflex, that is the sympathetic drive to run, fight, or flight or flight response. And noradrenaline, which is a cousin of adrenaline. Now, adrenaline is released when you're suddenly frightened or stressed. But the sympathetic nerves that are feeding the blood vessels, the arteries of the muscular wall of the blood vessels, feeding your heart to speed it up, feeding your gut, feeding all of these organ systems. So it's very important to realize that when the sympathetic neurons are activated, they're releasing at each organ noradrenaline, which is a kind of a packageable form of adrenaline. It's noradrenaline. And noradrenaline does the same thing as adrenaline. It speeds up the heart rate. If you give something that blocks noradrenaline, called Inderal, it slows down the heart rate and lowers blood pressure. So the sympathetic drive is mediated by noradrenaline, which is a cousin of adrenaline. So it's very easy to remember what the sympathetic nervous system does. It's what's very active when you're going to be ready to do some intense activity, like running, fighting, etc. Now, it's always active, just as the parasympathetic system is always active. Let me talk about I'm talking about when you can see the sympathetic nervous system in its full glory is when you're ready to fight or flight, okay? But it's active all the time to maintain the tone of your arteries, the muscular tone of the arteries. You know, the arteries can dilate and constrict depending on how much blood flow is needed to what part of the body. And the autonomic nervous system controls that, and the constriction part is mediated by noradrenaline, the sympathetic drive. The sympathetic drive is what increases your heart rate. The parasympathetic drive at its maximum, you can see after eating a meal. So an older person after eating a meal gets very drowsy. The pupils get smaller. Unlike adrenaline effect, the pupils are big. The parasympathetic response, pupils get small. The heart rate slows down, blood pressure lowers. The juices in your gut are active. So it's the way to think of the parasympathetic nervous system in full activity is an older person after a big meal. That's typical of a parasympathetic overdrive, you know. So, but when you think about it, at any given moment, it's like when you're driving a car, we have access to the accelerator and the brake. So the heart, for example, its rate has to adjust based on the needs of blood of the various organs that receive the blood. So if you need to increase blood flow, you turn on the sympathetic drive. If you need to decrease it, you turn on the parasympathetic drive. The parasympathetic drive slows down the heart rate. In fact, the major nerve from the parasympathetic nervous system is called the vagus nerve. And what it does is slow down the heart rate. It has a whole bunch of other kind of effects counter to what noradrenaline does. So that's the neuroanatomical basis of the autonomic nervous system. These are automatic movements. It's mediated by a complex set of neurons and connections. Would have central representation in the brain, but the autonomic nervous system is throughout the body, wherever you have organs. There's another thing the autonomic nervous system does. Talking about normal health. It is what regulates the amount of pilar erection and the temperature control of the skin. So it can kind of promote perspiration. If it's really hot, it sends your hypothalamus will pick up. It's really hot, you have too much body heat, you have to increase your breathing and you start sweating. Well, the sweating is mediated by the autonomic nervous system. Feelings of hot and cold are mediated by the autonomic nervous system. So, what goes wrong in Parkinson's disease with the autonomic nervous system? First, you have to realize that the autonomic nervous system is involved by the neuropathological process. For example, the nervous system of the gut, part of the autonomic nervous system, is a network. It looks almost like webbing around the intestine, in between the muscle layers of the intestines, throughout the whole gut, from the esophagus all the way to the anus. You have autonomic nerves forming a plexus, which is a network that mediates bowel movement. Well, within that nerve network, you can find Lewy bodies. In fact, some people have claimed you can make a diagnosis of Parkinson's disease by taking a rectal biopsy and looking for Lewy bodies, because it's present there very early on. And so as the Lewy bodies accumulate, the autonomic nervous system becomes involved. Therefore, what happens if the network that regulates bowel starts dysfunction? Well, you become constipated. You have less bowel movements. And this happens very early on, many times well before the diagnosis of Parkinson's disease. So that's an example of the neuroanatomy being of the autonomic nervous system getting involved in the pathology, the disease process, resulting in symptoms that we've talked about, which is constipation. So that's the biggie. Constipation is one of those non-motor symptoms that is due to involvement of the autonomic nervous system. Luckily, there's a lot of things you can do about that. Changing your diet, the amount of fluids, using a kind of diuretic laxative, not diuretic, osmotic laxatives, etc. The other biggie, the big issue about the autonomic nervous system that leads to a lot of problems in Parkinson's disease is the involvement of the sympathetic drive in the nervous system. So the sympathetic neurons can also become ill and develop the pathology, and the ability to adjust the caliber of the arteries, especially the large arteries, the carotids, that regulate blood flow to the brain, is that one cannot regulate blood flow to the brain anymore when you have this problem. So people will notice that as dizziness when they stand up. Why is that? Well, it's because we have what's called a pressure sensor in the carotid arteries, the two major arteries that feed into the anterior part of the brain. The posterior are called vertebral arteries. Well, the carotid artery has just like you have thermostats to monitor the temperature. If it's too low, it turns on the heat. If it's too high, it turns on the cool. Well, you have a baroreceptor that measures blood pressure. When the blood pressure is dropping, it sends the message to the sympathetic nervous system to constrict the vessels. Otherwise, you don't get enough blood flow to the brain. So automatically, when we change posture, what happens is gravity is always pulling blood down. And normally, you don't feel any change in blood flow to the brain because automatically the blood flow to the brain is increased, constriction slightly of the arteries, so that you don't notice lightheadedness or dizziness because the blood flow is upregulated when you stand up. But if you have Parkinson's disease, the involvement of the sympathetic nervous system is such that you don't have that compensation. So people will notice, I feel dizzy when I get up. And that may be noticeable early on or later. And it gradually affects everyone because as the illness advances, there's more and more blunting of that response, a change in position. So going from lying to sitting can result in people feeling lightheaded. If you lie back, you feel better. Now, what makes it even worse in the case of Parkinson's disease, this autonomic nervous system disruption, is that levodopa and dopamine agonists aggravate this response. They block that effect even more. So when you take levodopa or dopamine agonists, any synthetic dopamine like Requip, Maripex, even the patch, Nupro, it'll worsen the blood pressure lowering effect. By themselves, they can lower blood pressure. And when you get up, you feel even more lightheaded. So many patients are limited in the amount of anti-Parkinson drugs they can take because of lightheadedness when they stand up, leading to falls, fainting and falls. And the way that we treat that, and that is a symptom that many patients develop, we treat it by increasing salt intake in these people, provided they don't have heart issues. So by increasing salt intake, your body holds on to more water in the blood. So the blood volume expands a bit. It's like putting air into a tire, automobile tire that's low in air, you just put in more air in. Well, if you have low blood pressure and it worsens when you stand, you put in more blood. And the way you have more blood volume is have more salt, because salt hangs on to water in your blood. So that's one of the first steps. Second step is to tell the kidneys to hang on to salt, and that'll increase the blood volume and prevent the drop in blood pressure when you stand up. And the third effect is to give a kind of adrenaline-like drug called midodrine. that will increase the tone throughout the arterial system. So this is a very common problem, this lightheadedness on standing. There's a name for it, orthostatic hypotension. Orthostatic refers to going to the upright position. Hypotension means drop in blood pressure. And the result of that is faint. So those are the two major autonomic nervous system derangements that we deal with all the time. Before I talk about a few of the other ones that are quite troublesome, like erectile dysfunction in men. Well, that is also an autonomic nervous system problem that can be worsened by some of these drugs that we use. And the sad thing is that some of these dopamine agonists increase fantasy about sex, but it doesn't increase the capacity to have sex. So it's very disappointing. People get on pramipexole, which is almost an aphrodisiac for some people, and they become obsessed about sexuality and sometimes bother their spouses excessively when they're not interested, and then they can't maintain an erection. So it's especially troublesome to men, the inability to maintain an erection. So everyone with Parkinson's disease will at some point have some autonomic nervous system symptoms. In some people, it's very mild and not a big problem. But in some people, the autonomic nervous system problems are far greater than slowness and rigidity of movement, and slowness of movement. And it occurs early on in the illness rather than later. When you see that pattern of severe low blood pressure, severe constipation with a bowel movement every 3 or 4 days, inability to empty the bladder, and so there's a lot of urinary frequency because you can't empty the bladder completely, feelings of hot and cold, night sweats, all of these autonomic nervous system features, when they're way out of proportion to the motor symptoms, is called the Shy-Drager syndrome. And it's one of the Parkinson plus syndromes, the atypical Parkinsonisms. Even though, as I mentioned, everyone with Parkinson's disease will have involvement of the autonomic nervous system at some point. So we think of the disorder as being primarily a problem of volitional movement, but it's not true, because what Parkinson's disease really does is interfere with automatic execution of learned motor programs that you learn volitionally, like walking, reaching, dancing, doing all kinds of things with your hands. You've had to learn this from childhood, from infancy. And it's done automatically. When you're healthy, you don't think about walking. You only start thinking about walking when you have pain in the limb, when you have arthritis, or if you have Parkinson's disease, you realize you can't walk automatically anymore. And if you try, it's almost like it doesn't work, because the automatic execution of walking is hampered by the disorder of this other part of the nervous system that mediates movement, called the basal ganglia or the extrapyramidal system. In the case of strokes, where you have the upper motor neurons involved, you can't walk either, but you're paralyzed because you've injured the whole motor system, not just the cortical spinal tract results in very fine, precise, fast movements, but also the automatic execution of movements is damaged when you have, like, say, a major cerebrovascular event resulting in paralysis. What's fascinating is that in the 19th century, they thought of Parkinson's disease as nothing but a paralysis with shaking. They called it paralysis agitans, agitated paralysis, because it looked to the early neurologists like a person had a stroke. They wouldn't swing one arm, they might drag a leg, but they had tremor. So he called it the shaking palsy. He didn't even give it a Latin name. He was a very good Englishman. So he called it an English name, which is the shaking palsy. Sounds very English, doesn't it? Now, what is palsy? It's Old English for paralysis. And what is paralysis but weakness? So he called it the shaking weakness, the shaking paralysis, the shaking palsy. And that name is kind of in the back of many people's memories. So when they hear palsy, they think of tremor. Oh yeah, I had the palsy, and they go like this. Well, palsy just means you're paralyzed. Doesn't mean you have this. So I like to educate my people and say, well, if you say palsy, remember you're not talking about tremor. You're talking about weakness. The shaking palsy is tremulous weakness, which in a sense characterize Parkinson's disease, but they're not really weak. If you were to test each muscle individually, they're strong. What it is you fatigue very quickly with repetitious movements. If you start repeating the movement after a while, you can't. And it's hard to initiate movement. And once you're moving, it's hard to stop, so you keep going forward and fall. So that's all I'm going to say about the autonomic nervous system. You're already familiar with this because I've given a lot of talks about these non-motor features of the illness. It's actually where we need the most help in terms of development of medications. We really don't have good ways to treat a lot of these things. We rely on trial and error. So I'm going to just take some questions now in this topic, I hope.
Good to see you again. I have this problem where I start out walking, and it goes faster and faster and faster. I can't stop. And if I were on a beach, I'd go until my own muscles were exhausted and then fall down.
That what you described was given a name by James. We called it festination, or hastening gait, the tendency to walk a little faster. And pretty soon you walk faster to prevent falling on your face. And retropulsion can happen too, but the festinating gait, that's the term festination in Latin means hastening, so you're quickening, a quickening gait. That had nothing to do with the autonomic nervous system, but what do we do about it? It's a matter of physical therapy. Gait and balance training is what the best approach. There's no medicine that's going to help that unless that happens to occur when you're wearing off and you have that problem more likely because you don't have the medication on board. Then we would try to adjust your medicine.
Well, I find using the walker slows me down and using the walker slows me down. Mm-hmm. So that helps a lot.
Yes, so assistive devices are helpful. Any other questions, Frank?
Cialis was invented to make more potent men. Is there any counterpart on the women's side? Are you going to develop any kind of pills?
What Cialis does is allow the blood to be maintained in the penis, so it allows the erection to be maintained. It won't increase libido. And so yeah, that's how Viagra and Cialis work in that way. For women, they've tried these in women, and what it does is increase the blood retention in the vagina. So but it doesn't. Again, it doesn't improve, say, desire or anything like that. But there is no female aphrodisiac. Oh, you need the microphone? You can't read my lips? Okay. Well, this is such a delicate issue, talking about sex. You shouldn't, But we're adults. So for women, there is really no known aphrodisiac. There are for men, but as far as we know, I think for women, the best aphrodisiac is chocolate and roses. And a little glass of wine. Other questions?
Thank you for coming, Doctor. I've seen your tapes hundreds of times. They're fantastic. I'm on Nupro, 8 milligrams, 1 milligram of Asiac, and I'm feeling lightheaded, like you discussed. And I'm definitely going to try salt. But how do you?
Well, the first step is get a blood pressure monitor. Take your blood pressure sitting, stand up, wait a minute. If you feel lightheaded, sit down because you don't want to pass out. But after a couple of minutes, that's when the blood would start dropping from decreased blood flow to the brain. Take it again. If the systolic blood pressure, which is the high number, drops 20 points, that diagnoses the fact that you have a problem. And usually, if you feel lightheaded, it correlates with a drop of 20 millimeters. So if your pressure sitting is 120 over 80, when you stand up, it goes to 100 over 70. Well, that drop of 20 points confirms the diagnosis of, quote, orthostatic hypotension. Now, that definitely has to be treated, and by taking salt with each meal. In other words, we're told to avoid salt to keep our blood pressure low. And that's what you do if you have high blood pressure. If your tire is overinflated, you let out the air. If your blood pressure is high, you let out blood. In the old days, they used to bleed you with leeches. Now we do diuretics. Make you pee, it lowers the blood volume. Restrict salt, lowers the blood volume. So the opposite has to be done. You have to increase the salt. If you do that for a week or two and still feel lightheaded, then we gave you a medication called Florinef. It's a drug that tells the kidneys, don't let the salt be eliminated in the urine, hold on to it. So it maintains salt higher than it is normal, and that will increase your blood pressure. That's usually like 0.1 milligram at night. And finally, if people with Shy-Drager need this third step, they are taking salt in large amounts, sometimes salt tablets. They're taking Florinef to increase the blood volume. And they need Midodrine, which is a sympathomimetic drug. Now, you heard about sympathetic system. That's like adrenaline. A sympathomimetic drug would be an amphetamine or Midodrine. They mimic adrenaline. So they mimic the sympathetic nervous system. So Midodrine stimulates constriction of the arterial walls. So it'd be dangerous for someone with high blood pressure because you can constrict it completely and then you get a stroke. So all of this, by the way, should be managed by your physician. The thing that you can do at home is monitor your blood pressure and bring the list of your blood pressure sitting and standing throughout the day for a week to your physician, and they can then decide. Now, what normally I would do if it's really severe, I'd say cut back on the anti-Parkinson drug until we get your pressure up and then go back on the anti-Parkinson drug. But it's hard to do that when you're on the patch.
I know.
So in your case, since you're not fainting, you're just feeling lightheaded when you get up, start with the salt.
Okay.
I have that problem acting out. In fact, the last time I did it, I happened to be in my doctor's office.
And your pressure dropped that? Did you faint or came close to?
I would wind up on the floor looking up at a nurse staring me in the face.
Well, that's nature's way of treating orthostatic hypotension, is lying flat. That's why you faint. And as soon as you're lying flat, blood comes back to the brain, you wake up and say, what happened?
Yeah.
But even healthy people, if they're standing up in the heat, young recruits in training, you know how they are, those horrible officers, make them stand at attention for 3 hours, 95-degree weather, and pretty soon all their arteries are dilating, gravity's pushing down, and there's no way they can maintain the blood flow to the brain, and they drop like flies. As soon as they're on the ground, then they start, getting blood flow to the brain and wake up. So fainting is so I don't want you to faint, but if you feel lightheaded, immediately sit down and lie down, even better. So that's the solution if you feel an impending lightheadedness. Don't try to fight it and keep on walking, because you're going to end up forcibly to the ground. I'll take one from here.
Okay. My husband is diagnosed with Parkinson's, but he's afraid to take the levodopa. But if he does start taking it, he also takes heart meds, so, diuretics and all of that. So how do you balance?
It's not an unusual problem. There's a lot of people in this country with high blood pressure, congestive heart failure, a whole bunch of things like that. And then they develop Parkinson's disease. If it's truly Parkinson's disease, levodopa will alleviate the slowness and rigidity. However, people that have these chronic hypertension and heart disease could have what's called vascular Parkinsonism, in which case levodopa wouldn't be that helpful. But I see many people who have a history of high blood pressure. They're on antihypertensive drugs, several of them. Their blood pressure is under pretty good control. I give them levodopa and their blood pressure, it works, their Parkinsonism is better, but as we increase the anti-PD medicine like levodopa, and the illness advances over the years, they begin to experience this lightheadedness. First thing I do is tell them, meet with your cardiologist, we have to cut back on your blood pressure pills. So rather than stopping the anti-Parkinson drugs, which, by the way, lowers blood pressure, it ends up taking the place. In other words, the disease itself and the anti-Parkinson drugs will cure the hypertension. So you have to let him know that in some patients, they've been able to get off their Cozar and their diuretics and whatever they're on, because their levodopa was lowering the pressure so much, and their disease was lowering the blood pressure. So that's how you manage it. It's a balance. There's nothing that isn't a balance in medicine. So, go ahead.
My husband, Jim, has a recent diagnosis of Parkinson, and I'm noticing that he gets very cold. The house is at 76 degrees, and he wears wool socks and fleece pants and a sweatshirt and all that. Is that part of what you were talking about?
Absolutely. But if it's very severe, and like his feelings of cold is much more, it seems a little exaggerated, it's a very simple matter to check his thyroid hormone, because it's the other situation. It's very common in Parkinson's disease to have low thyroid and to feel cold when you're not feeling cold.
Oh, yeah.
But it's very common to feel cold, but they go through almost like menopause, flashes of heat with incredible sweating, so they drench the sheets. And you have to get up and change your pajama. Yeah. Does he have that? Or is it just feeling cold?
For a long time. I mean, I think a lot
So
of
it's hot and
this
cold.
was, you know, going on but never diagnosed. It's just, you know, probably for years, but at night, yes, drenched.
Yeah,
You know,
so
take
that's
lunch.
definitely the autonomic nervous system finding. And so, the temperature is set pretty cool at night because you sleep better.
Yes,
And you'll
74.
sweat even though the temperature is cold.
Yes.
So remember I said there's a need for
Yes.
medications for dealing with autonomic nervous system. And that's the one, I know of nothing that helps that other than physical things. Like, put powder on the sheet so when he sweats, at least he's not soaked, it absorbs with it's hard. I don't know what to do about severe night sweats and feelings of cold. But to be safe, I would check his thyroid hormone. It's a pretty common night sweats and hot and cold episodes. One more question and I'm going to go and prepare for clinic. There's one over here.
Could you give a definition of the vascular Parkinson's? Because you came back to, my husband, this is my husband Ryan, and we recently diagnosed less than a year ago, and he has a cardiac issue and is on low blood pressure medication, but does not have high blood pressure. He's on medication because of preventative.
The lower, I see, so you have congestive heart failure? CHF. And so they'll take blood pressure medicines to lower the afterloads of the heart because it pumps so hard. The higher your blood pressure, the more your heart has to pump, the heart becomes hypertrophic and creates problems. It gets so big and infected, the heart begins to fail. Then you start getting deep in the extremities and in the lungs. That's congestive heart failure. And one of the ways to treat it is to decrease the afterload with blood pressure medicines, or even levodopa is used to lower the afterload, decreasing blood pressure. And if it's congestive heart failure, they give drugs like digoxin to increase the strength of contraction of each heartbeat. But, so, what was the question?
Vascular Parkinson's.
Oh, yeah. Well, vascular Parkinsonism is a subtype of a Parkinson's syndrome that I see a lot here because the patients who are referred to this clinic have been seen by neurologists already. And if they're not doing very well on levodopa, they tend to be sent to them. And a good number of them turn out not to have idiopathic Parkinson's disease that gets better with levodopa. They have this following pattern, which is typical for vascular Parkinsonism. Later age of onset. The average age of diagnosis is 60, so the first symptoms across this country occur in the late 50s, with a neurologist finally concluding at the age of 60, that's the average age. The average age of diagnosis of vascular Parkinsonism is closer to 80, late 70s. It begins in the 70s, doesn't begin at 60s or 50s or 40s. It begins with a gait problem, not with tremor, not with unilateral decreased arms. It begins with a gait like with arms real loose. This is how lower body Parkinsonism begins. See how my arms are loose? Parkinson's disease begins with one side being slightly flexed and they don't swing one arm. And they may be a little stoop in small steps. Then eventually it's more. But lower body Parkinsonism is all in the lower body, nothing in the upper. When you examine them, they have no rigidity. Dexterity is fine. But with time, in vascular Parkinsonism, their upper extremities also become involved. So you can detect some rigidity and some slowness, but it's not, unlike Parkinson's disease, which is unilateral in onset and always remains one side predominant over another. In vascular Parkinsonism, it's more symmetrical. And what is the pathology and how we can diagnose it? By doing an MRI of the brain and looking at the response of levodopa. So with levodopa, they don't have a honeymoon period, they don't have much of a response. When you get to really big doses, and they can tolerate those, They may get a little better, but they still have problems with gait balance. Secondly, the MRI shows a lot of what we call ischemic demyelination in the white matter. It means all of those tiny capillary penetrating vessels have been occluded over time and results in predominant involvement of there's a little map of the man with the legs are up here, the arms are here.
Yeah.
Well, the terminal blood vessels are the ones that supply the legs, and those are the ones that first become occluded, so the leg symptoms become apparent first. And eventually, as the pathology progresses, and the pathology is microvascular occlusion. Each word means something. Vascular is blood vessels. Micro, they're the microvessels like capillaries. They're the terminal vessels of the arterial tree. It's like the twigs on an oak tree. You know, if you lose a branch of one of these oak trees, you'll see it right away. Just like if you occlude a large branch of your brain, you're going to be paralyzed on the opposite side of your body and not be able to speak. But what if you occlude the tiny twigs in an oak tree? You might notice a thinning out of the leaves. But you'd have to be a very good observer to notice that this tree has a lot less leaves because it's diffuse. The same with lower body Parkinsonism and microvascular disorder. It's a gradual occlusion of these twigs, these capillaries, and it results in a different profile. Now, there's another kind of vascular Parkinsonism. By the way, 8% of postmortem brains that have been examined at the UK Brain Bank that were in life diagnosed with Parkinson's disease, 8% of those showed microvascular occlusions, and the clinical story was like I described. Later age of onset, symmetrical onset, legs involved more, etc. So that's vascular Parkinsonism. However, there are people that have strokes that are called Lacunar strokes. They can be young, 40s, 30s. And if you occlude a vessel that supplies the basal ganglia, you could have a movement disorder. And usually you have multiple small lacunes, so you don't ever really quite present with lower body Parkinsonism. You present with a stroke-like syndrome that has some Parkinsonism, but may also have some other features that, depending on what territory was occluded, what vascular territory was damaged by the stroke. There is, for example, a brainstem stroke that results in Parkinsonism and action tremors, a rubral tremor. And that you can see with an MRI scan. So there are different strokes that result in Parkinsonism, but it's not the same thing as saying vascular Parkinsonism. Okay, one more question, that's it.
My husband was diagnosed with Lewy body slash Parkinsonism, and I noticed that he has a hard time using both his hands at the same time. Is that part of it?
Of course. Ask any Parkinson's disease patient to do anything with both hands at once, or to multitask, or to plan ahead and switch sets. Always, that's part of the cognitive issue. It's, Lewy body Parkinsonism just means he responded to levodopa, he presented classically. The only way they'd know it really was Lewy body Parkinsonism if they looked at his brain under a microscope. So if they told you that, they'd say, this looks like classical Parkinson's disease because it began on one side, he had the features, and he got better with levodopa. That's consistent with idiopathic Parkinson's disease, known as Lewy body Parkinson's disease. So, but they didn't look at his brain, did they?
Well, they did an MRI.
Yeah, that's not the same thing.
No, right, yeah, no.
Yeah, so no one should be called Lewy body Parkinson's disease, because that's a pathological diagnosis. They could be called Parkinson's disease responsive to levodopa, i.e. idiopathic Parkinson's disease. That's how it should be called. But to say it's Lewy body Parkinson slash Parkinsonism, however, if he had a lot of dementia way before his Parkinsonism and has some mild motor problems, then you call it dementia with Lewy bodies, because that is a clinical phenotype that invariably will show Lewy bodies there. But even then, I don't like calling it dementia with Lewy bodies until we see that there are Lewy bodies.
What are Lewy bodies?
Ask them. All you have to do, there's a frequently asked questions and ask the doctor, just write in Lewy bodies. You'll see tons of articles that I put up on the web.
Okay.
Secondly, every time I give a talk about this, we talk about the pathology. And Lewy body is the hallmark pathological inclusion that we see accumulate in brain cells, and they spread. That's all Lewy body is. It's something, again, it was named in honor of a neuropathologist named Lewy.
Louis.
Yeah.
I wonder.
Yeah. And these are nothing but, like with every neurodegenerative disease that you can think of, there's usually an accumulation of an abnormal material that cannot be broken down and recycled. In the case of Parkinson's disease, those intracellular inclusions, the garbage that accumulates inside the cells that cause demise of cells, are called Lewy bodies. In the case of Alzheimer's, they're called neurofibrillary tangles, and there's an extracellular component called amyloid, beta amyloid. In Huntington's disease, they're called HTT, Huntington protein. In ALS, there's acute nuclear and intracytoplasmic inclusions. So for every disorder, there's a very unique, abnormal accumulation of material that has been misfolded, misproduced, and impossible to digest. So, but please, everyone, look at the website. I was saying, you know, some of them are good. I mean, I've looked at the videos, it's boring to me, 'cause, you know, but I was saying, you know, if you don't know anything about Parkinson's disease, every month, I don't know, we have, it goes back for years, and we talk about everything. In fact, we're doing the same talks with slight variations, so I don't bore everyone, or myself. So, okay.
Thank you, Dr.